program, Spina Functional Anatomy Seminars.com. Today I'm going to demonstrate what I like to call a push adjustment for the lumbar spine. I call it a push not because I'm doing anything with my hands, because as we all know, what you're doing with your hands during the manipulation doesn't really affect how the manipulation goes. But I call it a push because of the way my body is going to push down on the person's lumbar spine. Importantly, what I want to discuss is proper patient positioning in order that you don't have to completely torque out the person's low back. In a lot of cases of acute low back pain, if you want to manipulate or mobilize a certain area, a lot of people tend not to get the manipulation unless they completely kind of wring out the patient before they put their thrust in, and their thrust is often very, very aggressive. With proper patient setup, you should be able to gap the area that you want the manipulation to occur in without having to torque out the person's body all that much. Now, I realize the research of Dr. Ross and Dr. Beresnik have demonstrated that the cavitation cannot occur exactly where you want the cavitation to occur, meaning that you can't be specific to the cavitation. But with the setup I'm about to show, you'll best be able to gap the joint that you want to put the motion into, and therefore, when you put your thrust through, a lot of the force will go to that joint. Whether or not that joint cavitates, it's not really the most important thing. The most important thing is to create motion at that segment. So what we're going to do to set up, we're going to do a lower lumbar manipulation about L5-S1. So what I'm going to do is, first of all, I'm going to have my patient directly up on her shoulder and lying perfectly straight. Then I'm going to bend the top leg, keeping the bottom leg straight. Okay. So I set up into an almost regular lumbar spine manipulation position. And then what I'm going to do is I'm going to palpate for the segment I want. Let's say in this case I want L5-S1. So I'm going to put my two fingers in the interspinous space, or you can use 2 fingers in the interspinous space of the joint above and the joint below. With the leg movement, I'm then going to flex the knee until I feel that joint space begins to open. So until I feel flexion or a separation of the interspinous spaces at my fingers. Because it's a lower manipulation, there's no need for me to bring the knee all the way up. The more you flex the knee up, the higher up that gapping will occur. But I want the gapping to occur just at L5-S1. So I'm in the interspinous spaces, and I'm going to go until I feel my fingers separate. I don't know if you can see this. They start to separate right there. Now from that position, I'm going to grab the person's arm. I'm going to tell her to lay perfectly still, and I'm going to pull her arm until I feel the top interspinous space move inferiorly relative to the bottom interspinous space. So what I'm doing here is I'm torquing out that exact segment. And in this case, because it's a lower segment, I will have to push a little bit more to get torsion. But you notice that the person's back is not completely wringed out. So if it's an acute low back pain case, I won't be causing pain in order to achieve the manipulation. So I felt my bottom finger move inferiorly and they've gapped. So now I'm going to take the contact directly on that spinous. I'm not going to move the thigh. I'm going to leave it wherever I had placed it in order to get the interspinous spaces to gap. And now I'm going to bring her forward close to me very, very slightly, so there's almost no rotation. And then the manipulation occurred in that little impulse thrust. Notice there was no need to bring her pelvis right over. The patient I'm demonstrating on is a professional dancer, so as you can see, she's incredibly flexible. So where most people would do the manipulation in an extreme range of motion here, with the proper setup, you can achieve the same manipulation with almost no rotation, or very little rotation, which is more comfortable for the patient. Okay.
Wait, hold on.
Okay, so again, fingers interspinous space. I'm going to flex the knee until my fingers begin to open, right there. I'm going to rotate just to the point where I feel my fingers start to separate, right there. You notice the patient's not in a lot of rotation. I'm going to contact that spinous, torque it very slightly. The manipulation already happened. And there's that one. Okay, so to demonstrate what we just talked about on the spine model here, if you see the interspinous spaces here, let's say I went and I did L5-S1. I took my contact in the interspinous spaces at L5-S1, and what I did was I used the leg, so leg flexion is going to bring the pelvis into, or the sacrum into counter-nutation. So as soon as the sacrum begins to counter-nutate, I'm opening or I'm gapping the segment that I want. So now I have that segment gapped. So let's say the leg ended up in this position. Now from that position, I'm going to take the person's upper body using their arm, and I'm going to rotate them until I feel a gapping between the L5 and S1 region. So I want to feel my top finger moving away because of the rotation occurring, and my bottom finger moving proximally. So what I've done here, as you can see, is I've completely gapped, or I've maximally gapped the L5-S1 region by doing that, by bringing the interspinal space away from each other, and then pulling one forward and one going downward. So I've opened them this way, and I've also caused rotation. So from that position now, I would take my contact, and I would put the contact onto S5. I would have a tight body position with almost no further rotation. So what I've avoided doing is I've avoided torquing out the person's entire body in hopes of only torquing out the joint that I want manipulated. So I'm going to contact that L5-S1. I'm going to keep my arm very, very tight along my body, and then it's just an impulse thrust, and you need very little thrust for something like this, and you're just going to push down. And you'll find that the joint will manipulate, cavitate very, very easily without having to put an incredible body drop into the person's pelvis, without having to torque them out, especially with an acute patient. So this positioning should be used, I use it for all of my patients, whether or not it be an acute or chronic case. And I also use it especially for people, as you can see, the person I demonstrated on was a professional dancer, very, very flexible. So people that are very, very flexible, once again, you want to try to gap that space without torquing out their entire body. I guess that's about it. So stay tuned for more blog posts. Thanks.